Hello, my name is Marco Valgimigli. I'm Deputy Chief of Cardiocentro Ticino Institute in Lugano, Switzerland, and I'm an interventional cardiologist. We ran a sub-analysis of the MASTER-DAPT study where we ask a specific question related to the complexity of intervention that the patient received. MASTER-DAPT is a large international study recruiting more than 4,000 patients who were at high bleeding risk and underwent PCI with ultimaster stent implantation. Patients have been selected for being high bleeding risk patient, but apart from this, they were free to get into the study in a pretty much all-comer basis. So at the end of the study, we did gather patients undergoing complex and non-complex PCI. We already presented the overall study findings at EAC and then TCT last year. The focus of the sub-analysis was really to ask the question whether the study findings are consistent in patients irrespective of PCI complexity. We defined complex PCI in the traditional way of at least a fulfillment of one of 6 key elements, including a 3-vessel PCI, at least 3 stents implanted, an overall stent length of at least 60 millimeter, a CTO intervention, or a bifurcation stenting. When we classify the patient according to complex PCI, yes or no, we ended up having roughly 1,200 patients fulfilling the complex PCI criteria, and the remaining patient undergoing non-complex PCI. When we look into the consistency of the 3 co-primary endpoints being NACE, MACE, and major or non-major clinically relevant major bleeding, we did see that there was no signal of interaction, which basically meant that there was no excess of NACE, no excess of MACE, and a significant advantage in bleeding complications in patients undergoing an abbreviated DAPT regimen, irrespective of PCI complexity. We also ran multiple sensitivity analysis, including an alternative and broader complex PCI definition. We also defined the so-called complex patients, which is a combination of either the fulfillment of complex PCI criteria and or ACS at presentation. And we also look into the combination of these 2 factors, complex PCI and ACS alone. And to make a long story short, our data does suggest that the results are remaining entirely consistent, meaning that in whatever patient subset we looked into, there is no excess of NACE or MACE, and there is a clear and consistent advantage in bleeding complication favoring abbreviated DPT over a standard DPT duration. This study is extremely important because if you shorten DPT down to 1 month, as we did in MASTER-DAPT patient, even in patient at high bleeding risk, there is of course a remaining concern that ischemic benefit may actually play a role, and that could be a trade-off with respect to a slightly higher ischemic risk. Therefore, looking into the complex PCI population in whom we know the ischemic risk is by definition higher, and by seeing that the results are remaining entirely consistent, is very reassuring and is telling a very important piece of information for us clinicians. Even in patients undergoing complex PCI, if they are high bleeding risk, 1 month DAPT followed by single antiplatelet therapy, either aspirin or a P2Y12 inhibitor monotherapy, is safe, and actually safer as it does not increase ischemic complication and is associated with lower bleeding complications. I think the multiple sub-analysis that we did in MASTER-DAPT in conjunction with the overall study findings are for the time being extremely reassuring. And the study is really telling the story that if a patient is an HBR, is a truly high bleeding risk patient, irrespective of the concomitant ischemic risk being acute ACS at presentation, being a complex PCI, that patient should actually receive 1 month DPT, at least as long as an ultimaster stent has been implanted, because we should not forget that our study was exclusively including patients who underwent ultimaster stent implantation. In patients who are identified upfront before the PCI procedure being at high bleeding risk, according to the criteria that were implemented in the study, which pretty much followed the Academic Research Consortium HBR framework, 1 month DPT is most likely the way to go, followed by single antiplatelet therapy. That does not mean that DPT should never be longer than 1 month, but our study is very reassuring, and 1 month DPT seems really the way to go. We are very active in identifying whether by looking to specific patient subsets, we will be able to identify at least some of them, or at least one of them, in whom the ischemic risk may outweigh the bleeding benefit. For the time being, that has not been the case. We have separately analyzed patients with or without oral anticoagulation. We have separately analyzed patients with or without acute coronary syndrome, and now patients with or without complex PCI. The data are extremely sound and consistent, and for the time being, there is no signal that deviation from a 1 month EPT regimen is justified and justifiable.